So thank you very much. Thank you to the SAS Foundation. Thank you, Dr. Coleman, Dr. Nivinsky. It's definitely a great honor to have been selected, and especially in this country, which has a lot of great hematologists. And I also, of course, I consider this is also an award for the French myeloma group. And Philippe said very kind words, and he said that we are part of the IFM, which is a very friendly organization. I do believe we did some good studies in the past 20 years, and many of them in the younger transplant-eligible patients, and some of them in the elderly patients as well. So thank you again. That's definitely a great honor to have been to receive this award, to have been selected. So my presentation this evening is on the elderly newly diagnosed myeloma patients, and these are my disclosures. And my first slide is just to say that myeloma is primarily a disease of elderly patients, in fact. So we got a nice debate this afternoon on transplant, on younger patients eligible for transplant, but it's definitely a disease for the elderly. What is shown on the right-hand side is your US epidemiology program, showing that the median age is 69. Approximately 1/3 of patients have an age over 75, and 10% of patients have an age over 85. What is shown on the left-hand side is not myeloma. It's just the world population and the proportion of people with an age over 65, showing that in all countries, in fact, in the next 20 years, we will see more and more elderly citizens. And if you want to combine these two pictures, in fact, that just says that the younger hematologists in the room will have to treat more and more myeloma patients in the next 20 to 30 years. I would like to start with a patient case. I had to comment at the time of the last ASH meeting in 2016, and the case was proposed by Dr. Rifkin from the US, and he asked me to discuss a 75-year-old gentleman who had no past medical history, and he was recently diagnosed with myeloma. And the first question was, would you consider this patient eligible for stem cell transplantation? And again, he was 75-year-old. And as you know, the audience was very international. Some colleagues from the US, but also many colleagues from other parts of the world. And I was quite surprised to see that, in fact, 45% of colleagues say that this patient was potentially transplant eligible. 41% say no, and 14% say not sure. In fact, it's one thing is to say that a patient is potentially transplant eligible, but then the next question was, what is your initial approach for this elderly myeloma patient? And as you can see, 1/3 of colleagues were in favor of some bortezomib-based regimen, so the VMP or the VCD or Cyborg-D. Lenalidomide and Dex is in 11% for 11% of colleagues. Thalidomide-based regimens and carfilzomib-based regimens were quite infrequent. VRD for 23% of colleagues, and then in fact, transplant was done for approximately 1/4 of colleagues. So it just means that treatment options are extremely variable, and going from the 2-drug regimens to 3-drug regimens, and potentially transplant for some patients, including some patients up to the age of 75. If you want to go back to recommendations, I am a European hematologist, so we have the recently published ESMO Guidelines. This is a publication from Dr. Moreau on behalf of the group. And the options for the elderly are shown on the right-hand side. And again, you will find this bortezomib, melphalan, prednisone regimen, or you may say also the combination with cyclophosphamide. You will find lenalidomide in combination with low-dose dexamethasone on the VRD regimen as well, so the combination of bortezomib, lenalidomide, and dexamethasone, which has not been approved yet, but which is part of ESMO recommendations. If you want to go to some US recommendations, and I will not show you NCCN guidelines, we heard about this afternoon, these are the Mayo Clinic recommendations. And as you can see, there is a global recommendation for the VRD regimen, lenalidomide and dexamethasone being suitable for patients over the age of 75. But in fact, the European recommendation is not that far from the US recommendations. If you want to go back to what we did in the past 10 years, and as said by Philippe, I would like to go back to this MPT experience. And you may say it's a little bit old-fashioned, in fact, but I have mainly two reasons to mention this. The first reason is to say that thalidomide is still an effective drug for myeloma patients. And in many countries, in fact, lenalidomide and pomalidomide are not fully available and fully affordable. So it's still an important drug for many myeloma patients around the world. My other comment would be for Dr. Balogi, because he rediscovered thalidomide for myeloma patients in 1998. And I have to say that, in fact, we were followers. We were quite fast followers, but the great job was done basically by Dr. Balogi for looking at this thalidomide story. So this regimen was approved 10 years ago, and approximately at the same time we got this melphalan, prednisone, bortezomib regimen. So this was the VISTA study. As you know, the VISTA study was published 3 times, and this is the last issue of the VISTA study, published in 2013. And as you know, they found a very nice TTP benefit, which translated into a survival benefit. So the median survival for the VMP regimen was 56 months. That is approximately 5 years. After this VISTA study, we got recently other studies having a VMP control arm, and this is one example. So this is the carfilzomib MP versus bortezomib MP study, referred as the CLARION study, which was presented for the first time at the IMWG meeting in India earlier this year. And as you can see, the study did not meet its primary endpoint of progression-free survival. So the median PFS was the same, was VMP on KMP, approximately 22 months. A little bit more response for the carfilzomib MP regimen, a little bit more complete response as well. The survival was not mature, but was the same. So the study did not meet its primary endpoint, but I still believe the study is important, also because it's a very large study for VMP. Approximately 500 patients received this VMP regimen, and this VMP regimen was was the most recent, in the sense that approximately 70% of patients received subcutaneous bortezomib. So I still believe this is something important. Most recently, we did not get study results, but we got a press release for this other study having a VMP control arm. So this is what is called the Alcyon study. So we heard about Castor and Pollux this afternoon. So this is Alcyon. I do not know the story, to be honest, but and so Alcyon is basically VMP versus VMP in combination with daratumumab, and the primary endpoint is PFS. So the press release is shown on the here. So it was said that the study met its primary endpoint of PFS, and the hazard ratio was 0.5, which is quite impressive. The median PFS for patients who received the VMP was approximately 18 months. And so this is what we have today. But for sure, this is a positive study. And we are eagerly waiting for the study results of this Alcyon study. After this VMP or VMP-based studies, in fact, it's fair to say that another important study, as mentioned by Philippe, was the first study. So the first study was initially designed by the IFM. So for us, it's the IFM 2007-01, meaning that the study was designed more than 10 years ago. And this is also called MM20. And because we had a background of MPT in our country, the control arm was melphalan prednisone in combination with thalidomide, and we decided to investigate two lenalidomide and dexamethasone arms, one given for 18 cycles, the other one given continuously, and the primary endpoint was PFS. I said sometimes that it was the largest study done for approval in myeloma, but in fact it's not true, because the denosumab study we have seen just before has enrolled more than 1,700 patients. So it's the largest study done for registration, but still it's a large randomized phase 3 international study. And so this is the PFS and the survival. So the median PFS for the continuous arm was 26 months versus approximately 21 months for the two other arms. And looking at the survival was significantly better for those patients who got lenalidomide and low-dose dexamethasone. The two arms, in fact, the median survival for the lenalidomide and dexamethasone arms was approximately 5 years versus 4 years for those patients who received melphalan prednisone in combination with thalidomide. And also importantly, and it has been a matter of debate, in fact, there was no survival difference between Lendex 18 cycles and Lendex given continuously. I would like here to mention another study, which is a kind of different experience of continuous lenalidomide, at least for some patients. So this is the Myeloma XI study from the UK. It's a very large phase 3 study, and the study has enrolled approximately 1,500 patients, and 50% of these patients are elderly. And as you can see, at the time of diagnosis, patients received either the CTD, cyclophosphamide, thalidomide, dexamethasone, or the CRD regimen with lenalidomide. And then there was another randomization for lenalidomide maintenance versus observation. So you may say that some of these patients, in fact, received lenalidomide from the beginning, and they got some lenalidomide maintenance as well. And this is the PFS for the transplant ineligible patients. Median PFS being 11 months for those patients who were in the observation arm versus 2 years for those patients who received lenalidomide. So this study also speaks for the role of continuous therapy with lenalidomide, having this part of lenalidomide maintenance. After the first study, we recently got the results of this SWOG study done in the US. So this is an academic US study which had enrolled approximately 500 patients. And in fact, the control arm was continuous lenalidomide and dexamethasone, and the investigational arm was 8 cycles of VRD followed by lenalidomide and dexamethasone. So the study has been published in the Lancet earlier this year, and I will go into the PFS and the survival, but I have to say that the study was not fully dedicated to the elderly. And this is probably important to keep in mind. In fact, if you look at the study population, in fact, only 43% of patients had an age over 65, and also it's probably important to say that few patients had renal insufficiency, few patients had ECOG 2, for example. So this is not a study focusing on elderly. Some of these patients were, in fact, young patients with newly diagnosed myeloma. But on the other hand, the study was strongly positive in favor of the VRD regimen. So this is the PFS on the left-hand side. And as you can see, the median PFS for the lenalidomide and dexamethasone arm was 30 months versus 43 months for the VRD arm. And this translated into a nice survival benefit. So the median survival being 64 months for lenalidomide and dexamethasone versus 75 months for the VRD regimen. So in fact, these are important study results, even though they are not being observed in a fully elderly population. And these results, in fact, are in line with what we observed in the first study. And in the first study, we had median survival approximately 5 years in patients over the age of 65. So I do believe this is an important study, and that may lead, at the end of the day, to the approval of this VRD regimen for transplant-ineligible patients with myeloma. Besides this VRD experience, and this was also said by Philippe, we have several, at least we have 3 large ongoing phase 3 randomized studies, which are international studies for the elderly. So the first one is and these 3 studies have a lenalidomide and dexamethasone control arm. So this is the elotuzumab study. The investigational arm is elotuzumab in combination with lenalidomide and dexamethasone. This is the ixazomib study, and this is the daratumumab study, which is called the Maya study. And in fact, we say that these are partly IFM studies. In fact, approximately 50% of patients in these 2 studies are in fact French patients. And so I do believe that the first 2 studies will present study results very likely next year, and we may have to wait a little bit more for the daratumumab study. But these are 3 important studies done for registrations, and that will likely lead to the registration of several new regimens for the elderly myeloma patients at the time of diagnosis. Here I would like also to mention another US study, which is an academic study. This is an ongoing study, but I do believe that many of you are participating in this study. In fact, this is VRD versus carfilzomib, lenalidomide, and dexamethasone. I have been told that the study will have to, as enrolled the patients, in fact, but the study will be extended. So I have been told that we may expect study results in the next 2 years or something like that. But this is also something which is important. Here I would like to say some words on fitness versus frailty, because I do believe this is something relevant. And if you look at fitness versus frailty, it's fair to say that this work has been pioneered by Dr. Palumbo and colleagues, and this is what is shown here is the International Myeloma Working Group frailty score, which was published in Blood in 2015, and this is definitely a very influential work, drawing the attention of the myeloma community to the need of a very good frailty assessment. So what was done by Dr. Palumbo and colleagues, he looked at age, comorbidities, and he looked at 2 quality of life questionnaires, and he was able to establish a score defining fit patients, intermediate patients, and frail patients. And then at the end of the day, he was able to say that these different patient populations may receive different regimens. So it's a little bit old-fashioned, but it will still be valid in the next few years with other regimens as well. And so this is this is very nice work. You may say this is a little bit expected, but in fact he was able to show that the frail patients had a reduced survival. The frail patients had also a quite limited median PFS. They got more non-hematological adverse events, and they discontinued treatment more frequently. So this is something which is, again, very important. And in the IFM, we try to do something a little bit different. So this is what we call the never-ending IFM frailty score, because we still we worked a lot on this, and it's still not published, but hopefully this may be published one day. So we looked at the first study database, and we did not have LDL and ILDL. We had simple things, in fact. We had age, we had comorbidities, and we had ECOG. And we looked at on these three parameters. And we also tried to define only two populations, the frail and the non-frail, because we did consider that it was not so easy to have an intermediate group. So we tried to do with that, and in fact it was not so bad. As you can see, the frail patients had a reduced PFS, and if you look at the survival, in fact, the median survival for the frail patients was approximately 40 months, and it was 70 months for the non-frail patients. So I'm not saying this is something optimal, and I do believe that many other colleagues around the world will try to design other scores, and colleagues in Germany did a score as well, colleagues in the US as well. But I think that it's something important, and I would not say a dream, but my myeloma dream would be probably to combine all the studies I have shown before, putting together probably something like 5,000 patients, trying to design something optimal, and this will be something useful in the next few years. The reason why I'm saying it will be useful is that we start to see studies for fit patients and studies for frail patients. And in fact, this was driven, from my point of view, by the VRD regimen. At the time, we had only VMP, lenalidomide and dex, or MP in combination with thalidomide. This regimen was suitable for frail and non-frail patients. At the time you move forward with the VRD regimen, you may say that some elderly, very frail patients will not be able to tolerate VRD. And you may say that they will not be able to tolerate VRD in combination with other new agents. So at the time you move on with the VRD, you have to make a distinction between frail and non-frail patients. And in fact, this is recognized in some ongoing studies. So this study is a Spanish academic study for fit elderly patients. And in fact, you can understand that these patients have to be fit because the control arm is VMP followed by lenalidomide and dexamethasone. This is KRD. This is KRD in combination with daratumumab. Patients will receive consolidation, and then they will be randomized for maintenance between lenalidomide and lenalidomide in combination with daratumumab. So this is just one example of a planned study designed for fit elderly patients. And in fact, the IFM did something different for the frail. And we designed something very simple, which just says that this is lenalidomide and low-dose dexamethasone, and this is lenalidomide in combination with subcutaneous daratumumab. So the study is basically a dexamethasone sparing study, and we say that we would like to take advantage of the subcutaneous daratumumab to replace, in a certain extent, dexamethasone. And so this is a study for the frail. So the point is not to say that this study is excellent or this study is optimal, but these two studies are extremely different. And we will start seeing studies for frail and studies for fit elderly patients in the next few years. Just a couple of slides on transplant eligibility and I would say the transplant eligibility discussion for the elderly patient. So we could spend a lot of time on this, and I have only 2 slides. The first bullet point is just to say that, as said by Philippe this afternoon, transplant remains a standard of care for the younger, newly diagnosed elderly patient, newly diagnosed myeloma patients, and this is based on the IFM 2009 and European Myeloma Network study. So you may say there was a debate, a nice debate this afternoon, and you may say this could be. It could be a debate, but as I do believe that it's still that would be the advice of the majority of European centers at least. There is no large phase 3 randomized study establishing the role of transplant in elderly fit patients in the era of novel agents. On the other hand, we know that in many countries, in fact, patients over the age of 65, usually patients between 65 and 75 proceed to stem cell transplantation. And then we had we had a nice debate inside the IFM some months ago. We said basically, do we need another study asking the role for frontline transplant in patients over the age of 65? And that the debate was very friendly, but the debate was a little bit tough, in fact. And you have so the question was, do we need a new transplant study in elderly fit patients? If yes, is it still possible? And so some people say yes. Dr. Moreau said yes. I was in favor, I have to say. And we said basically no clear answer on the benefit of transplant in elderly, no randomized study in the era of new agents. Especially looking at, we will do additional progress with CD38 antibodies, but some other people say no. And for example, Dr. Attal, who is very well known in the group for transplant studies, say no. Professor Hauso say no as well. And they say basically that these two studies have shown benefit for transplant in the younger newly diagnosed myeloma patient, but we are not totally sure that all patients will benefit from transplant. And finally, we also say that the control arm will be excellent. So if you can put together an immediate PI, a CD38 antibody, and dexamethasone, your median PFS will be likely quite long. We said, let's say, maybe something like 50 months. So that will be very difficult to show the superiority of transplant. And finally, we said also that the risk may outweigh the benefit, especially for patients over the age of 70. So finally, we decided not to move forward with a new transplant study for the elderly. And in fact, I showed you just before the Spanish study, having VMP lenalidomide dex versus KRD versus KRD-DARA. And if you look at this particular study, you can say also that our Spanish colleagues decided not to proceed to transplant in elderly newly diagnosed myeloma patients. Finally, this would be my conclusion for today, and this is what has been done in the past 10 years and what is ongoing. Basically, the starting point was melphalan prednisone. At that time, the median survival was approximately 30 months. As I said before, we investigate several MP-based regimens, so MP in combination with either bortezomib, thalidomide, or lenalidomide. And so the median survival is approximately 4 years for patients receiving MP in combination with thalidomide. No direct comparison between VMP and lenalidomide and dexamethasone. This is the first study showing the superiority of Lendex over MPT. The median survival is now approximately 5 years. These are the ongoing studies we have discussed just before. Not all of them, but many of them are based on lenalidomide and dexamethasone. And then these are potentially the new studies, at least for the fit elderly patients. I think that the frail elderly patients will have to receive something a little bit different, so a kind of more gentle regimen, having, for example, a PI or an IMID in combination with a CD38. But the fit elderly will likely receive a VRD in combination with a CD38, or you may say IRD in combination with a CD38. And we may expect that at that time the median survival will possibly be between 6 years and 7 years. So this is something which is likely important, because if we can get median survival approximately 7 years in elderly newly diagnosed myeloma patients, that means basically that some of these patients will die from something different. They will not die from myeloma. So that's not exactly a cure, but but on the other hand, we can say that it's some kind of progress in the field. So this was my last slide, and this is the IFM group. So just to be clear, it's a little bit white on red. That was a dress code, because that was an IFM meeting 2 years ago in the nice city of Biarritz. And Biarritz is the southwest part of the country, and the colors of Biarritz are the red and the white. So this is the reason why many people are in white and red. Usually it's not the case, it's not a general finding. But this is a very nice group, and again, it's a great honor for this group and for myself to have received this award. Thank you very much for your attention.